First and foremost, at the end of the day, healthcare providers are expected to improve the health of patients. If we didn't want our physicians and nurses and allied health professionals to help patients live longer, happier, healthier lives, then we wouldn't bother training them. So at the end of the day, that's what we want. And so by measuring patient outcomes, we can assess how well we are fulfilling our contract with society to provide competent healthcare providers. It also helps us to focus on those aspects of training that are really important. So, for example, one of the things that I think has really come out of this focus on patient outcomes over the past 10 years is the focus on team training and the need for interprofessional education, and also the need for us to focus on physicians that can work in systems of care, not just the one practitioner in the room with a single patient, but stepping out of the room and looking at the other aspects of the healthcare system. Physicians have to be able to deal with that. And by focusing on patient outcomes, we are able to appreciate that. It also helps us understand that a lot of the things that we do in lecture halls really doesn't translate to observable behaviors in the clinic and have no demonstrable impact on patients. So it helps us to identify the priorities, helps us to guarantee to the public that we're responding to their needs, and helps us to really understand what works. At the end of the day, what works for medical education. And so again, I don't think that there's anything wrong with patient outcomes inherently, but there are some challenges and some potential pitfalls that we must appreciate, or we're going to wind up in a situation where we really don't want to be. Thousands and tens of thousands of patients are enrolled in a lot of the research studies looking at potential benefits for heart failure and stroke and lung disease and kidney disease. And even if a physician implemented all of those evidence-based treatments 100% effectively, their impact on a patient's life would still be difficult to detect in a feasible research study. And so then to think that by training them differently, we'll be able to impact those same outcomes is simply kind of quite ludicrous, to be honest. There's no way that I'll be able to have a demonstrable impact on patient outcomes through most of the training initiatives that I'll be doing on a daily basis. That problem of dilution. Related to that is the problem of feasibility, a very practical issue that I'm not going to be able to conduct a research study. It constrains the questions that I can ask and answer. Thinking about this from a clinical perspective, not all research studies are designed, clinical research studies, they're not designed to improve patient mortality. Maybe they're designed to improve the creatinine, or to resolve a patient's anemia, or to diagnose a condition at an earlier stage. And if those initial treatments work, then we progress down the line to studies that look at patient mortality, patient morbidity, and so forth. But the initial foray focuses on much more proximate outcomes. The third issue has to do with confounding. This is an issue of study design. Most patient outcome studies are, of necessity, using a relatively weak study design, a single group pre-test, post-test study, or a case control study. And those designs allow very weak inferences about causality. At the end of the day, you just don't know if it was the intervention that you did or something entirely else, something entirely different, unrelated to what you did, that caused the outcome change that you observed. And so you may or may not detect a change, but even if you do, you don't know what caused it. Story very briefly of a man looking under a lamppost for his keys, but in reality his keys were dropped on the other side of the street, but the light was better under the lamppost, so that's why he was looking there. The same is true for the educational outcomes that sometimes we look at when we look at patient-related outcomes. We're selecting the outcomes that are easy to assess, that are accessible, as compared to the studies, the outcomes that are most important. Learning, we know that, but sometimes it forces us to teach to the test. If we know what the outcome is going to be, then we're going to focus our teaching activities to achieve that outcome. And that's good to the degree that those outcomes are what is most important for the care of our patients. But oftentimes we're selecting those outcomes based on convenience, or there is no clear standard of care for patients, and in those situations, even in the absence of a clear standard of care, a clear outcome that is defensively a better outcome than the other, those are still important things to teach on. And so if we teach only to the outcomes that we can demonstrate, then we're going to be ignoring an awful lot of other things that are potentially very important. I think the first thing we need to do is focus on the objectives first. That's true in research studies, and I think it's true for our training activities as well. We first decide what topic is it that I want to teach on, or if it's a research study, what is the research question. Then I deliberately would select the outcome measures that I think will give me the best answer, the best information for that training activity or that research study. After I've done that, I can select the instruments that I think will measure those outcomes with greatest rigor or greatest defensibility. But by focusing on the objective, it forces us to pause and consider the strengths and weaknesses of some of the different options available to us. Second, I think we can consider the use of surrogate outcomes. For example, I could do a research study that first validates a more proximate outcome, a skill in a simulation setting or a behavior at the bedside, and I can link that with a patient outcome with some degree of confidence and rigor, and then I can use that outcome in a more tightly, that surrogate outcome in a more tightly controlled research study, a randomized controlled trial or a study with a concurrent control group, and by having established this link, I'm able to establish a greater rigor in the research studies I'm conducting, and at the end of the day, I'll be able to say with greater certainty that what it was that I was doing as a training intervention led to the improved outcomes I desired. Now, there are some flaws with that. Surrogate outcomes are not perfect, but it's one possible solution here to that problem.